Ringrazio le famiglie.
Thank you very much to the families that are here today, to the organizers of this event, to the association that organized this event for giving us the opportunity to talk about this very complex disease and also unexplored disease. I will give an introduction about the general features of cognitive development, and my colleague Dr. Ricci will talk about neurovisual features. As we have heard so far, encephalopathy associated that is associated with GNAO1 and as with a broad spectrum of neurological phenotypes with various combinations of epilepsy, developmental delay, and hyperkinetic and also intellectual disability. On physiopathology, a lot has been said by Dr. Balente. So let's move on and let's talk about the correlation between genotype and phenotype. That is important, and it is important to score, to underline the need from the point of view of the research and the clinicians to stress what the phenotype is and every genetic condition, every genetically determined condition. And we know the correlation between genotype and phenotype is very complex because a phenotype can have its own variability, inter-individual variability, but also variability within the same patient throughout different stages of development for possible modifications, activation or deactivation of some functions of the gene that can happen during development, but also because of environmental factors. As far as encephalopathy associated with the GNAO1, the core of the phenotype is characterized by movement disorders that we see in most patients, and epilepsy that is present in over half of the patients. But another thing that is always present is the cognitive delay, cognitive disorders. But if we take a look at the literature and at the data that are available, as far as development is concerned, we know that this is present in most patients, but there are no details about what are the specific features of this delay. In particular, many of the studies that stress these aspects have not found differences in patients with epilepsy or without epilepsy when it comes to development. The most recent study done by Kelly, Dr. Kelly, that presents 14 cases, and this study has been mentioned several times. In this study, the 9 patients that had epilepsy, all of them had cognitive disorders, and patients with movement disorders the study shows that one patient with movement disorder had the normal IQ, and 4 of them had not severe cognitive disorder. However, there are no details on how these cognitive disorders were assessed, so it can be said what was the cause of it. So we think that it's important to try and define if there exists also in encephalopathies with a GNAO1 mutation, a cognitive behavioral profile that is specific to this. This is important not only for research, but also for the practical life of children, for everyday life of children, because it allows us to define the presence of points of strength or points of weakness associated with the competencies and the skills of every single child, and this information can be used in rehabilitation therapy and can also be used to foster learning processes. So we need to say that adaptive and cognitive profile of every child with any kind of neurological condition envisages the combination of different skills, movement skills, neuropsychological competences, verbal competences, and social competences, social skills. As you can imagine, with this genetic condition, movement skills are impaired, as well as verbal skills. Neuropsychological skills are difficult to explore, and social skills seem to be more normal. To give an example, with standard tests for cognitive development and cognitive skills of older children, if we take as an example the most used scale, which is the Griffith mental development scale, to analyze the profile, we have to use scales that require especially movement skills that cannot be applied to children with the GNAO1 mutation. Also, the Vineland scale that is usually used with older children still requires some movement skills that these children unfortunately do not have. However, in the clinical practice, I'll show you an example of a baby girl with a GNAO1 mutation. We have been following this case since she was born, basically, since her first weeks of life. And through her first year of life, she had very severe case of epilepsy with more than one seizure per day. She presented severe hypotonia, delay in cognitive development, but throughout observation, she also developed a movement disorder, but throughout the evolution and the observation, what has always struck us, it was her interaction, her intentions to communicate. To say it in simple words is like if she spoke with her eyes and with the movement of her face. So we thought it was quite obvious to try and assess if it was possible to examine visual functions, to analyze what are the cognitive processes or the prerequisites of cognitive processes. In our hospital that was founded by Professor Guzzetta, that I would like to thank because he was not only founder of children neuropsychiatry, but he was also a mentor to all of us. So thanks to his input and his insight, it was possible to study visual function, and we applied the study of this visual function also to the syndrome of Western syndrome of Agrave and Dravet syndrome, and it allowed us to understand what was happening even before the delay happened. So we thought it was useful to verify if in children with the GNAO1 mutation, how these visual functions worked. So together with Professor Ricci and her team, she and her team, they work with us. So together with them, we applied these scales of assessment, the neurovisual scales of assessment, to this group of children. And their age is in between 2 and 8 years. All of them have a GNAO1 mutation. All of them have a movement disorder. The onset happened at different stages. Some of them started at 5 months, some of them at 3 years of age. Just 3 of them have epilepsy, and just one of them has hyperventricular intensity. Some of them take drugs against epilepsy. As you can see, they all have movement impairments, and only 4 children have reached control of the trunk. Only one can actually grasp things. Whereas if we consider social interaction, that was assessed through social smile, triangulation of sight, facial movements, and communication intentionality. It was present in all the patients that we observed. Speech is compromised in all the patients when it comes to speaking, whereas comprehension that is not assessed in an objective way, but has been assessed through what the parents had to say, seems to be quite normal. So at this point, we thought it was useful to assess what visual functions can tell us. As Lila Dubovitz said, visual assessments can provide a unique window on the brain in early life, and we try to see what we could understand and what we could use through the visual function. And we understood that the visual assessment can actually be used to improve learning processes in these children, and we tried to define the characteristics. Now, Professor Ricci will take it from here, and she will explain the results.
Ok, e allora io vi mostro come abbiamo giocato.
I'll show you how we played, because this is what we do. We play. Usually, I don't do more serious things. So we try to understand what's the behavior of these children in response to some activities that we presented. There are some visual functions that are considered as basics, and those allow to build information, of course, for those who can use sight. So the first one is fixation. Fixation is the ability to fix the sight on a target and on the fovea. The fovea is the part of the eye that allows us to see at our best. I usually fixate my target. I look right in front of me. If you can keep that for more than 3 seconds, it means there is a stable fixation. It means that I am able to acquire information. If not, I can't acquire information. I actually lose information. Another very important thing that we do assess since the neonatal age is the maximum distance of fixation, which is also said maximum distance of visual attention. Think of an object that is 8 or 10 centimeters big. A baby that is 3 months old can keep fixation up to 10 meters. So a baby that is 3 months old can actually see everything that happens around him in a room that is 10 meters big. So if I cannot keep the fixation, I know I don't have that kind of information. There is an explanation here, different symbols for two things. The white circle is when it's present. The white circle with the star is when it's stable. The black circle is when fixation lasts less than 3 seconds. And as you can see, we have very good children. On a distance of fixation, if it's at least 3 meters, so we have a white circle, black circle is less than 3 meters. Good results, as you can see. So we saw how chasing is. What is chasing? Chasing is the capacity to follow with your sight something that is moving. So we have a low chasing that we do following the person, and we usually evaluate the 3 types of chasing: horizontal chasing, vertical chasing, and a circular chasing, because it requires different skills. Horizontal following, chasing, if you want, is already complete in children that are younger than 40 weeks of age. So the ones who are born early at 33 weeks, for instance, already have that fully developed. So it's a very early skill that they develop. So the one with the star, white circle and star, is complete. The one without the star, it has some difficulties. Horizontal, very good. Vertical, the same symbols. So the ones with the stars is complete. Just the white circle, it has difficulties on one side. Again, good results. When we talk about the circular chasing, circular motion, you see how there are more difficulties for children. But let's be careful, cautious because these children, since they've been described so well so far, they have postural problems because there is a movement disorder, because there might be a basic hypotonia. There might be many features and conditions. So if the posture is not correct, and this is not a criticism, it's just that it's hard to find the right posture for all the different situations that we experience during the day. But to use sight at its best, if the posture is not correct, of course this affects the way I see things. So when we look at our children, you have to remember that if you have to look around you, you do not have the same posture that you have when you're eating or when you're sleeping or when you're doing something else. So, saccades. Saccades are those rapid eye movements
Da un particolare all'altro.
that allows to see all the details. So looking at your faces, I move my eyes from one subject to the other. So I produce saccades, I express saccades. It means that I am assessing the bigger picture, the whole space that I have in front of me. If I can create saccades, good, I acquire the right number of information. If I don't, then I have a problem. So horizontal saccades, what do you think? Is that a good result? I would say yes, there is only one black circle. What about the vertical saccades? Way more difficult. But there are some that can actually express saccades. Children that have a head tilt and they start looking in this way, if they cannot have vertical movements with their eyes, they tilt their head, because tilting their head, using the muscles that work horizontally, they basically explore the space vertically. So before eliminating a posture that we think is wrong, let's verify if it's not a useful posture for children. So visual acuity, this is preferential looking. This is the capacity in very young, small children. There is this preferential looking, that it means to see something that is different from what is very homogeneous around you. So you see how stripes are increased in frequency and they are more similar to gray. The more stripes they can see, the better results they have. And we use this methodology, the Teller cards, since neonatal. Then there is sensibility to contrast, which allows us to understand, to identify the image also when it's very blurry. When a child is 1 year old, they can see the very blurry one 1 meter away from the image, from the picture. So let's see the results of our children. I'm not very happy with these results as I was with the ones before, because you see a lot of black circles. Unfortunately, these skills are more difficult for them, which doesn't mean that they don't have it. It doesn't mean that they don't have preferential looking or they don't have sensibility to contrast, but they're not mature enough if we consider their age. Let's take a look at stereopsy. Have you noticed that we have two eyes, but we only see one image? Why? Because when the information we get from the two eyes, they come... Somebody is signaling number 3. Oh, no, actually, they're signaling that she has 3 minutes left. I thought she was saying that we have 3 eyes. So stereopsis, I was saying that the brain combines all the information that we get from the two eyes, and it gives us information about depth, tridimensionality, and distance. Usually, children that are strabic don't have the two eyes on the same line. They send information to the brain that are not identical, so the brain chooses one of the two eyes, and the other one is set aside, so to say. Stereopsis, this is not mature. It seemed to be absent in all of our children, and strabism was present in only one child. We have, so the lack of maturity does not depend on strabism, and it seems to have other causes. So, putting all these results together, as you can see, the white areas are the ones that are alike. So halfway we have most white circles, so fixation, distance, saccades, and so on. While the rest, it's mostly black. So if we analyze these skills, we can say that those who seem to mature better are the ones that allow us to perceive. So I can fixate, I can observe everything that I have around me, I acquire information to understand what surrounds me, and I can organize an archive of information also through images that then we all use when we recognize what we have in front of us or around us, when we have to couple what we have in our brain with what we have in front of us, when we have to call things by name. Whereas when we take a look at these other skills, the maturity of the cortex seems to be delayed, especially when it comes to stereopsis, but also the quantity of sight as acuity helps us to program the movement. So that kind of information plus the reduction of the movement capacity in general provides less information. Elena was the child that we observed, she was mentioned before, and we could observe her for a long, long time. Thanks to parents, we've seen 7 children, but 6 of them, we have seen them only once. Some of them have come to us when they were 8 years of age. Elena, that we could observe from the very first weeks of life, we can see how she matured those skills. She started with black circles, but then those circles became white. And this is a good indication. These functions that are specific for Elena, you can see how good the results are. What doesn't change, though, is those black circles that we had in other children as well. Those did not improve. If we take a look at the literature that is available, it says the capacity to move, to shift attention from one object to another has a higher sensibility from the 5 months of age. And that gives us indication of how the child will move when he's 2 years of age. So this is a very important component of the visual function. And more recent studies of this Swedish team shows that ocular movements is correlated with movement development at the age of 3. So it's something that we really need to take into consideration. Our window on cognitive development. And thanks to Elena, who is here today with the colleagues who follow her. So she's here with her extended family, and she went to do this test with a height tracker. Because as Dr. Battaglia was saying, it looks like she speaks with her eyes. And in fact, she answered with her eyes. I need help instead, though, because with technology, but here we go. It's the first time she sees this. It's the first time she sees this therapist. It's the first time she plays with this device. She was fixating the circle, the moving circle that you see. It's Elena's eyes. See how she stopped with her eyes because she was listening to what the therapist was asking. So the therapist is giving instructions. Take the look away from the screen and then back on the screen. Assessment of the visual function. It's a reinforcement and support of visual components, and that can be a great help to develop other kind of competencies like cognitive skills to come to a full assessment. So thank you to everybody else, because Dr. Battaglia and I wouldn't do this on our own. And a big, big thank to the families. It was a pleasure for us. And thanks to the colleagues who follow them, who work with them.